Hi, thanks, Jeremy. Good afternoon, everyone. So, like Jeremy said, I'm going to be presenting on liver abscesses, back to the basics. So, we'll try and cover as much as we can. So, in terms of definition, liver abscess is defined as a space-occupying lesion in the liver parenchyma, and it accounts for the majority of intra-abdominal visceral abscesses. And if we go back in time, it was actually first described around 400 BC by Hippocrates. And then the first case review was published in about 1938 with 47 cases described by a group called Oshner and colleagues. So in terms of what it is, it's a suppurative infection of the hepatic parenchyma, and this may be caused by bacteria, so that's a pyogenic abscess, and rarely by parasites and fungi. So there are three etiological classifications broadly, and they are divided into amoebic liver abscess, pyogenic or bacterial liver abscesses, and then fungal liver abscesses as well. So in terms of the epidemiology, there's quite significant geographic variation. And the countries that I found with the most data that came out was the United States and Taiwan. So I've juxtaposed these flags just to show you that, this is where most data has come from. But just to see the vast or the variation between the two. So the annual incidence in the United States is said to be about 3.6 cases per 100,000 individuals, whereas Taiwan has up to 17.6 cases per 100,000. But in developing countries, approximately two-thirds of cases are actually amoebic in origin, whereas in developed countries like the United States, pyogenic abscesses constitutes about three-quarters of all their cases. In terms of incidence, it has increased in the last few decades, and this is largely attributed to an increased recognition of the disease and probably due to more frequent use and maybe more access to imaging techniques. So there was very, very a little South African data that I could actually find. But I thought maybe it would be important for me to just highlight this study. So this was actually an MED that was done by one of our surgical registrars on the VITS circuit. So it is yet to be published. But this MED was basically looking at liver abscesses in patients between Charlotte Maxeke and Chris Hani Baragwanath Hospital over a 5-year period. So this study period was between 2015 and 2020, and they had found 222 patients presenting with liver abscesses. And quite interestingly, so the median age here across the board was about 48 years, and it had a slight male preponderance. The most common comorbid condition in these patients were HIV, and this was about 25% of the cohort. And then other comorbid conditions would include hypertension and diabetes. So you can see that hydatid and amoebic pathology is presented at a younger age, and hydatid disease was predominantly seen in females in this cohort. So I'll show you just a little bit more data from the study as we go along. So in terms of risk factors, historically, pyogenic liver abscesses was the result of intra-abdominal complications like that we would see with acute appendicitis. But nowadays, biliary tract disease seems to be the more common risk factor and is said to be accounting for about 40% of all cases, or the underlying pathology in about 40% of all these cases. But there is still about 55%, more than half of the cases that have unidentifiable risk factors, and these cases are said to be cryptogenic. In terms of other risk factors, so it would include things like diabetes, liver transplants, PPIs have been implicated, and then geography and host factors will also play a role. An example of the geographic risk factor would be East Asia, because we know that primary invasive liver abscess syndrome, secondary to Klebs pneumonia, has been described quite extensively in that part of the world. Other risk factors are chronic granulomatous disease, which is a rare genetic disorder secondary to NADPH oxidase inactivity or phagocyte issues. And these patients are actually at risk for liver abscesses as well. And studies from various regions in the world have suggested an association of pyogenic liver abscess with underlying colorectal cancer. So in some of these studies, liver abscess is caused by Klebs pneumoniae, which is the most common cause of liver abscess, pyogenic liver abscess in Asia. It appears to have quite a strong association with colorectal cancer. And in Asia, the long-term prevalence of actually developing colorectal cancer in patients with pyogenic liver abscess is said to be as high as 2 to 3%. And then we know that historically strep bovis infections, we've always been taught that if we find a strep bovis infection, that we need to be hunting for colon cancer because of that strong association. So the same is true for this Klebs pneumoniae, pyogenic liver abscess. So I think the important thing here is to just be aware of the risk factors and to actively hunt for the underlying pathology, especially malignancy in these patients. So treating the abscess is just not enough. In terms of mortality, there are quite a few prognostic factors, and these would include progression to sepsis, the development of multiple abscesses, polymicrobial infections, or developing infections with antimicrobial resistant pathogens. Also the elderly, so age more than 70 years, and if your abscess is associated with underlying neoplasia and immunosuppression. So these are all poor prognostic factors. But risk factors for mortality would include the need for open surgical drainage, again, the presence of malignancy, or even the presence, in this case, of anaerobic infection. And then obviously access plays a role here. So access to optimal diagnostics and interventional resources would be critical here to patient outcomes. So the primary differential diagnosis for any apparent liver abscess on imaging would be amoebic liver abscess secondary to entamoeba histolytica infection. Hepatic hydatid cyst is also a space-occupying lesion in the liver, and I'm going to talk about it a little bit. I know in some of the textbooks, when we're talking about liver abscesses, they refer you to another chapter with hydatid cysts, but I think because it is such an important differential, I'm going to include it in this talk at the end as well. So in terms of other differentials, so tuberculosis or tuberculous liver abscesses are also seen, and when they do occur, they usually manifest as smaller multiple abscesses. Then Burkholderia pseudomallei, which is responsible for causing melioidosis. This can usually be identified by growing the bug on the abscess of the abscess aspirate. And obviously, you need to consider this in areas of high endemicity. Hepatosplenic candidiasis is also heard of, and this is usually manifests as microabscesses throughout the liver parenchyma. And patients with hepatosplenic candidiasis often have underlying hematological malignancies. So there are a few other uncommon infectious causes, and this would include things like Bartonella, fasciola, endemic fungi, and these lesions tend to be a little smaller and nodular in nature. Then obviously we have to talk about non-infectious causes, and non-infectious causes can have a similar radiographic appearance, and things like necrotic tumors or biomas may be differentials here. And then obviously these things can be distinguished on histopathologic examination. Okay, so in terms of the microbiology, most pyogenic liver abscesses are polymicrobial in nature. So these are mixed enteric, facultative, and anaerobic species, being the most common pathogens. So anaerobes are probably underreported because of the difficulty to culture and characterize them in the lab. But other common etiologies include the enteric gram-negative bacilli, particularly E. coli and Klebs, like I mentioned earlier, the Klebs pneumoniae. And this is especially true, we said, in some parts of East Asia. In terms of other etiology, so streptococci used to be the most common pathogen, and I think in a few series I think I've read in the United States, streptococci were seen quite often. And this is particularly the Streptococcus milleri group. So this would be anginosus, constellatus, and intermedius. So staph and strep progenies are the gram-positives that are sometimes responsible. But if we find staph or strep, so if it's implicated, This should prompt the clinician to search for simultaneous metastatic infections at other locations. So things like infective endocarditis would be important to look out for. And like we said earlier, Candida co-infection along with typical bacteria has been described. Then this is just a table from Mendel, and just showing us that commonly we see E. coli and Klebsiella more than 10% in gram negatives. And then with regards to the gram positives, the anginosus group, the enterococci and other viridans streptococci also seem to be more common. And then I've just included a picture here of the hypervirulent strain of Klebsiella pneumoniae. So you can see this is actually a string test that's done in the lab, where you just take a loop and you pick up a colony. And if the colony has a string that extends to more than 5 millimeters, it's said to be suggestive of hypervirulent Klebsiella strain. Obviously, there's other ways of diagnosing it, like sequencing, but this is just a laboratory test, a quick laboratory test that may be suggestive if we are looking for it. So again, this is that study from WITS by Dr. K. Pillay et al. From 2024, that EMID. So in this cohort of those 222 patients, you can see it was mostly Klebsiella that was isolated, followed by E. coli at, 17%, and then quite a large proportion, 16% were still cryptogenic. And remember, these could still be anaerobic infections that weren't actually characterized in the laboratory. So in terms of the pathogenesis, so quite a considerable portion of pyogenic liver abscesses usually follows one or more episodes of portal vein pyemia. So another important route is direct spread from a biliary tract infection. And it said that up to 60% of these patients usually have some sort of underlying biliary tract disease. And this could be things like gallstones or even a malignant obstruction. Occasionally, the abscesses can come from penetrating wounds, or trauma, or any other surgical intervention. They may also result from hematogenous seeding from the systemic circulation. And like I mentioned earlier, a monomicrobial liver abscess due to strep or staph species should prompt the clinician to hunt quite actively for an additional source of infection. And I remember Ribka drumming this into my head during our ID rounds with Sharon when we were doing our registrar training in ID at Helen. So this is always something I would remember, is just to hunt for any underlying source. So this table again is taken from Mendel's, and then you can see quite a high frequency of biliary abnormalities underlying the pathogenesis in most cases of pyogenic abscesses. Okay, then in terms of clinical presentation, it said that only about 1 in 10 patients will present with the classic triad of fever, jaundice, and right upper quadrant tenderness. But patients may present with other non-specific symptoms, which would include things like nausea, vomiting, anorexia, weight loss, and malaise. In terms of abdominal signs and symptoms, they're usually localized to the right upper quadrant, and they include pain, guarding, and then what's also commonly described is this rocking sign, which is pain that's caused when you try to gently rock the patient's abdomen from side to side. Additionally, patients may also have rebound tenderness, but it's important to note that in the absence of right upper quadrant findings, it doesn't exclude the presence of liver abscesses. Okay, so moving to diagnosis. So in diagnosing pyogenic liver abscess, you often require a combination of clinical features together with imaging, like the use of ultrasound and CT scans, and then together with your microbiological findings. So in terms of imaging, ultrasound and CT are the first choice imaging studies for identification of the abscesses. CT is said to be slightly more sensitive than ultrasound. We're talking about 95 versus 85% sensitivity. But ultrasound is often more immediately available, especially in low resource settings like ours. And then if ultrasound fails to demonstrate any abnormality, but you are still highly suspicious of liver abscess, you may go ahead and do a CT. Imaging can also identify other intra-abdominal abnormalities. So like we say, we need to look for underlying biliary tree diseases. It's common in most of these pyogenic liver abscesses. So the CT might help us to look for these. And then in terms of laboratory workup, so a culture of the aspirated pus is the gold standard for diagnosis. Blood cultures are obviously essential as well, and they can be positive in up to half of these cases. And if possible, it's recommended that two sets, so both aerobic and anaerobic culture should be obtained. And this is obviously before the administration of empiric antibiotics. In terms of blood workup, so there's usually an elevated ALP, so elevated alkaline phosphatase concentration is the most frequently abnormal liver function test that comes back. PCTs may be elevated. And there was also a multivariate analysis of risk factors that I found, and this was in the States, that found that a hemoglobin concentration of less than 10 and a blood urea nitrogen of greater than 28, which is equivalent to in our standards, a urea of more than 10. So these together were predictors of mortality in patients found to have pyogenic liver abscesses, which was very interesting. And there's the study, if you are interested, I put at the bottom. In terms of additional workup, so it's recommended that you check the serology for entamoeba histolytica on the initial diagnosis, and this would be especially important for patients who don't have any evident predisposition to developing pyogenic abscesses, and those who are from endemic areas, so where you see it a lot. So the known risks for amoebic liver abscess will be those that are living in areas or traveling to endemic areas. But we know that amoebic liver abscess can occur in any region of the world. And then lastly, we do have 16S rRNA sequencing and sequencing that may be a useful technique in identifying the etiological agent in some instances, especially when you have culture negative results. Okay, so in terms of imaging again, so liver abscesses commonly involve the right lobe of the liver, and it's probably because of its larger blood supply than the other lobes. But the abscesses need to be distinguished from tumors and cysts, like I mentioned earlier. And sometimes we do have difficulty in distinguishing pyogenic liver abscesses from amoebic liver abscess, even from hydatid cysts. So I've put these images next to each other. To the untrained eye, like mine, it's very difficult to try and differentiate between them. But just to describe some of the things that you might see. So in hydatid, and why I'm highlighting this as well is because it was a recent case that I know Jeremy and Sharon had at Helen Joseph, where it just was so difficult to differentiate between the whether it was a pyogenic abscess or whether it was actually hydatid. And there were so many opinions from so many different radiologists, and the patient turned out, I think, to have a pyogenic abscess, if I'm not mistaken, at the end. But it can be incredibly difficult to differentiate these, even with trained eyes. But in terms of hydatid disease, you should be seeing septa and daughter cysts. And then commonly what's described as a water lily sign, which indicates that the cyst is floating with this undulating membrane, and it's caused by a detached endocyst. And I think it's more easily described on ultrasound, and I think that's an ultrasound picture of what the water lily sign should look like. In terms of amoebic cysts, they should be rounded, very well-defined lesions like the one you see in this image. They should have an enhancing wall with a peripheral zone of edema that's seen, and the thickness of the wall is said to be about between 3 and 15 millimeters. You may or may not see fluid debris or septations within the cyst. In terms of pyogenic abscess, so they should be peripherally enhancing and centrally hypoattenuating, and this is called a double target sign. So this is a characteristic imaging feature, although it's not always seen, but this is where you have a central low attenuation lesion that's fluid-filled, and this is surrounded by a high attenuation inner rim and then a low attenuation outer ring again, and that gives you that double target sign. In terms of the complications for pyogenic liver abscess, so abscess rupture, although a rare complication, is said to be occurring in about 4% of all patients. And risk factors for abscess rupture include a diameter of more than 6 centimeters and sometimes coexisting cirrhosis. And when these abscesses rupture, it's more commonly either in the perihepatic space or into the pleural space. So this, again, I'm going back to this IMMED study, and we could see that ruptured liver abscess was a complication in about 6 out of the 222 patients. And then one patient had developed a pleurobiliary fistula. Okay, in terms of the management, so broadly the management is divided into surgical management and medical management. And it's recommended that pyogenic abscesses are drained whenever it's practical and feasible. Percutaneous drainage should be guided with either ultrasound or CT, and simple aspiration of the abscess may be sufficient if it's a small abscess, but placement of a drainage catheter is just always preferred. So there were 2 large randomized control trials from India that I've listed at the bottom. And in these trials, it was shown that for pyogenic liver abscesses more than 5 centimeters in diameter, percutaneous catheter drainage reduced the time to recovery and shortened the hospital stay when it was compared to just percutaneous aspiration alone. In terms of other options for surgical intervention, so things that would include things like open surgical drainage, laparoscopic drainage, or drainage by ERCP. Then there's a new technique, endoscopic ultrasound guided drainage, which is an emerging technique that can be employed by medical gastroenterologists. It appears to be quite a safe and effective method of draining difficult to access liver abscesses. And then in terms of the recommendations, so single unilocular abscesses with a diameter smaller than 5 centimeters, a percutaneous drainage with either the catheter placement or a needle aspiration alone may be acceptable. But the choice between the two will depend on local availability. But catheter placement is preferred. If the catheter is inserted, it should remain in place until the drainage is minimal, and this can take even up to 7 days. In single unilocular abscesses where diameter is larger than 5 centimeters, drainage with placement of a catheter rather than just needle aspiration alone is preferred in these cases. So even very large abscesses, those that are larger than 10 centimeters, which are sometimes referred to as giant abscesses, can be successfully managed with catheter drainage, although the risk of treatment failure and other complications are still substantial, whichever the approach may be. And the decision on drainage approach for multiple or multiloculated abscesses should be made on an individual basis. And this should involve a multidisciplinary team, taking into account how many abscesses there are, how big they are, how accessible they are, and also taking into account the experience of the surgeons, the radiologists, and the patient factors, so whatever underlying comorbidities or conditions that they may have. Surgical drainage is indicated, though, for patients who have an inadequate response to percutaneous drainage. And this is after about 7 days of attempted treatment. It's also indicated for patients who have abscess with incredibly viscous contents that tends to obstruct the drainage catheter. And then in terms of medical treatment, successful medical treatment for liver abscesses without any surgical intervention has been described, but only in a few patients. And the patient characteristics associated with good outcomes with medical therapy alone is yet to be known. In terms of medical therapy, so these are the antimicrobials that are recommended, but there aren't any RCTs that have evaluated antibiotic regimens for the treatment of pyogenic liver abscesses. And the treatment recommendations are usually just based on the probable source of infection But it should obviously be guided by your local antibiogram and your own local bacterial resistance patterns if you know these. But in terms of empiric treatment, so empiric broad spectrum parenteral antibiotics should be administered while you are waiting the results of your aspiration and microbiological analysis. And your empiric regimen should cover the common bugs, so the streptococci, the enteric gram negatives, and the anaerobes. And your empiric regimen should also cover Entamoeba histolytica until the causative pathogens are found or amoebic abscesses are excluded. If the patient is in septic shock, for example, and if Staph aureus is a concern, so if this is your patient has identifiable risk factors for Staph aureus, like a patient with indwelling vascular catheters or an IV drug user, then maybe more appropriate staph-directed cover must be considered for these patients. So this table is actually from up to date, and you can see here their preferred regimen is a BL-BLI combination. So PIP-TAZ is what they would recommend. Or you could consider using a third generation cephalosporin like ceftriaxone with metronidazole, or ampicillin, gentamicin, and metronidazole as part of triple therapy. And your alternative regimens being a fluoroquinolone with metronidazole or any of the carbapenems. So once your culture and susceptibility results from your blood and your abscess specimens are available, then your antibiotic regimen can be tailored accordingly. There is, however, a recommendation to continue polymicrobial cover in some instances. And this would be true for things like strep viridans or the enterococci. And this is because these bugs are commonly associated with polymicrobial growth. And the consensus guidelines recommendations is that polymicrobial cover should be continued even when you isolate these bugs, so strep viri and enterococcus in particular. But on the other hand, if you isolate Staph aureus or Candida is the only organism, then you should be narrowing your spectrum because these organisms are commonly found in isolation and are less likely to affect a polymicrobial infection. But regardless of whether the causative organism has been identified, antibiotic therapy is suggested to continue for 4 to 6 weeks. And patients who have had an initial good response to drainage should be treated for about 2 to 4 weeks with IV therapy, while patients with incomplete response to drainage therapy should receive a longer duration, so suggested 4 to 6 weeks of parenteral therapy. Then in terms of oral switch, the remainder of the course can be completed with oral therapy that would be tailored to your culture and susceptibility results. But it's recommended that even if you don't have these results to tailor a regimen, and a reasonable empiric oral antibiotic choice would be augmentin or fluoroquinolone with metronidazole. In terms of the specific duration of antibiotic therapy, it's usually determined by the extent of the infection, the patient's individual response to treatment, and whatever underlying comorbidities they may have. Patients with abscesses that are not drained or are suboptimally drained usually require longer durations on an individualized basis. In terms of patient follow-up, because like mentioned earlier, retrospective data has suggested such a strong association with colorectal cancer and pyogenic liver abscesses, it's advised that screening for colorectal cancer should be done, and screening should be done maybe after the patient is discharged from hospital and once everything, or the patient has stabilized and has completed treatment. In terms of follow-up imaging, if follow-up imaging is generally not recommended unless the patient has persistent clinical symptoms or if your attempt at drainage is not proceeding like you expect it to. And the reason for this is that radiological abnormalities resolve much more slowly than clinical and biochemical markers. So doing imaging too early may cause unwarranted alarm and unnecessary continuation or sometimes even escalation of treatment interventions. But having said that, patients who have had persistent clinical symptoms with ongoing evidence of abscess on imaging, who have had drainage and antibiotic therapy, will require a reevaluation for either repeated drainage, or if repeated drainage can't be done, then they would need to be looked at for surgical intervention. Okay, so then I'm going to move to amoebic liver abscesses now. Um, Amoebic liver abscesses is the most common extraintestinal manifestation of amoebiasis. It's the fourth leading cause of mortality worldwide due to any parasitic infection and has an estimated 50,000 deaths annually. And it's caused by, we know, almost all are caused by Entamoeba histolytica. An amoebic liver abscess, sorry, excuse me, is 7 to 10 times more common among adult males than other demographic groups. And I really am, we're not sure what this unequal sex distribution is. So remember the disease itself, so colonic disease has an equal male and female preponderance, but invasive disease, so the presence of amoebic liver abscess is a lot more common in male. There has been some links to testosterone, but none of these have been validated. In terms of other factors predisposing to progression from intestinal amoebiasis to amoebic liver abscesses, it has been suggested that immunosuppression, especially with HIV, is associated. But there's some data that it may be potentially confounded by increased rates of oral anal sex in this population. So it might not be true. So we still don't know. In terms of clinical manifestations, patients with amoebic liver abscesses will usually present with 1 to 2 weeks of, again, right upper quadrant pain with fever, and the pain may be referred to the epigastrium or the right chest or even the right shoulder. Other symptoms will include cough, sweating, malaise, weight loss, anorexia, and they may even present with some diaphragmatic irritation with hiccups. Concurrent diarrhea is present in only less than a third of patients, although some patients will report a history of dysentery within the last few months. Physical examination may reveal a hepatomegaly and point tenderness over the liver, but this is only said to be true in about half of the cases. In terms of complications, rupture of the liver abscess can occur into any adjoining space or organ. An extension into the chest occurs almost 4 times more common as extension into the peritoneal cavity, but either can occur. Hepatic aneurysm and active hemorrhage is also associated with liver abscesses. And then you can get hepatic vein and inferior vena cava thrombosis, and this is usually secondary to mechanical compression and inflammation associated with a large abscess. And then you may get recurrent episodes of infection over many, many years despite adequate treatment, although this is quite rare. In terms of diagnosing amoebic liver abscesses, so it should be suspected in the setting of fever, right upper quadrant pain with relevant epidemiology, of course. So in the setting of suggestive findings on imaging, confirmatory serologic or antigen testing should be done. And if you can, you should also do stool microscopy or stool antigen testing. But it's most importantly, you should be looking for the parasite in the fluid, right? So approximately 99% of patients with amoebic liver abscesses will develop detectable antibodies, but this can be delayed by up to 7 days following infection. So it may not be as reliable. Antigen testing and or PCR of the aspirated material may also be helpful in establishing the diagnosis. And in terms of imaging, so radiographic imaging of the liver can be pursued with ultrasound. You can do a CT, or if you have access, you can do an MRI. And I've added chest X-ray here because you may see chest X-ray abnormalities in about half of the patients with amoebic liver abscesses, and the most commonly seen abnormality would be elevation of the right hemidiaphragm. But this alone obviously doesn't indicate any pulmonary involvement. In terms of repeating imaging, serial imaging again is not generally helpful because in these cases, the lesions may appear to increase in size or even number on ultrasound after the initiation of treatment. And this is even with appropriate therapy and with good clinical improvement. So serial imaging is not recommended in these cases. Okay, in terms of treatment, so patients with amoebic liver abscess should be treated with metronidazole. If you do have access, the literature states that tenidazole is also effective, and this is a once daily dose, so it's easier to take, a once daily 2-gram dose for shorter duration for 5 days, whereas metronidazole is recommended for 7 to 10 days. But the cure rate with either is said to be more than 90%. So then following invasive therapy for invasive amoebiasis, treatment with a luminal agent to eliminate intraluminal cysts is important. So even if the stool microscopy is negative, you should be using an intraluminal agent. And the suggestions are paramomycin or this tongue twister of a drug, diiodohydroxyquin, diloxanide, furoate. In terms of pregnancy, so the use of metronidazole we know in pregnancy is quite controversial because we know it does cross the placenta and it rapidly enters the fetal circulation. But there are obviously no well-controlled studies that demonstrate efficacy, safety data for metronidazole in pregnancy. So it should be used mainly in the setting of severe disease. But as an alternative, chloroquine is recommended, and this would be a dose of 600 base for 200 days. For 2 days, followed by 300 milligrams base for 3 weeks. So this chloroquine would be, in these cases, chloroquine will be an acceptable alternative. In cases of uncomplicated amoebic liver abscesses, there has been no benefit observed with drainage in addition to medical therapy, right? So aspiration or catheter drainage will only be warranted for patients with either a very large left lobe abscess or those with an inappropriate or clinical response within about 5 days of antimicrobial therapy, and also for those who have relapse following therapy. Okay, and then like I said earlier, I was just going to go through hydatid cysts quickly. And again, just because it can be a little bit of a diagnostic dilemma, especially when you're faced with this radiological findings and you need to try and differentiate between them. So I just thought I'd talk about it a little bit. So in terms of hydatid cysts, so it's echinococcal disease. It's caused by the infection of the metacystode stage of the Echinococcus tapeworm, and Echinococcus granulosus infection is the one that's usually implicated, and it frequently produces no symptoms, so you're often asymptomatic. But in approximately 25% of cases, the cysts rupture into the biliary tree and can produce features of biliary colic, obstructive jaundice, cholangitis, and even pancreatitis. Less commonly, the cysts may rupture into the peritoneal cavity or other organs, and they may cause anaphylaxis or even multi-organ failure. It may cause a pressure or mass effect on the bile ducts or the portal and hepatic veins, or sometimes even the inferior vena cava, and result in cholestasis, portal hypertension, venous obstruction, or even Budd-Chiari has been described. It can also cause a secondary bacterial infections, and that's when you will have a hydatid with a concomitant pyogenic liver abscess. So in terms of diagnosis, ELISA appears to be the most sensitive and specific of the available assays. PCR techniques are available, but they seem to be limited to research settings, but they may seem to play a diagnostic role in the future. So in the absence of a positive serological test, percutaneous aspiration may be required to confirm the diagnosis. And you do this and look for protoscolices or hooklets, and sometimes you may only find hooklets or even just the hydatid membranes. But percutaneous aspiration is associated with very low rates of complications. But this method of diagnosis is generally reserved for situations when other diagnostic methods are inconclusive. And this is because of the potential for anaphylaxis and secondary spread of the infection. The sensitivity of ultrasound for evaluating echinococcus is quite high. It's said to be about 90 to 95%. But CT is the best mode for determining the number, the size, and the exact anatomic location of the cysts, and is better than ultrasound for detection of extrahepatic cysts. And CT may also be used for monitoring the lesions during therapy and to detect any recurrences. ERCP may also be warranted, and this is to evaluate for biliary involvement, particularly in patients who present with cholestatic jaundice. So the treatment of echinococcus usually involves antiparasitic therapy combined with either surgical resection of the cyst or percutaneous aspiration with installation of scolesoidal agents, a PAIR procedure. So antiparasitic therapy may be used as definitive management in a select few cases, and it's also useful as an adjunctive therapy to surgery and percutaneous treatment. Albendazole is the primary antiparasitic agent for Echinococcus granulosus, but in the absence of albendazole, or if patients have severe adverse reactions to albendazole, you can use mebendazole, but it is less well absorbed, and the duration of therapy is a little bit longer. So this is the WHO classification for cystic echinococcus, and this is a very nice table that will tell you what the stage is and what the recommended treatment is. But initial management with drug treatment alone is appropriate for management of small WHO CE1 and CE3 cysts. And these would be cysts with maybe a single compartment and a diameter less than 5 centimeters. The optimal duration of therapy is really uncertain, but it's recommended to go on for 1 to 3 months. And this is really depending on the clinical factors, and sometimes up to 6 months may be required. Drug treatment alone is usually not effective for treatment of cysts with a diameter larger than 5 centimeters or for treatment of WHO stage CE2 or CE3B cysts. Other circumstances in which drug treatment alone may be warranted would include the management of multiple cysts that are less than 5 centimeters or cysts that are deep in the liver parenchyma that are not amenable to percutaneous treatment, or even peritoneal cysts. WHO CE4 and CE5, the last two at the bottom here, are inactive cysts, and antiparasitic treatment is not warranted in these cases. In terms of perioperative drug therapy with albendazole or mebendazole, if you don't have access to albendazole, it's said to reduce the risk of recurrent disease by inactivating the protoscolices. It also assists by softening the cyst, and it facilitates removal during the surgical procedure. The optimal duration of treatment here is uncertain, and there's two recommendations. So the WHO suggests that you should start the antiparasitic therapy 4 to 30 days preoperatively. This table is taken from up to date, and up to date suggests that it should be at least 4 days before surgery. Then you can see under the preferred treatment column, there is a modified catheterization as a recommendation. So this is a technique that's used to remove the entire endocyst and the daughter cysts from the cyst cavity. And what they do is they use these large bore catheters and cutting devices with an aspiration apparatus. And this approach is again done in combination with albendazole, and it may be appropriate for cysts that are difficult to drain just with PAIR. That's PAIR therapy, and for managements of cysts that are classified as CE2 or CE3B cysts, which may have compartments within them. And these are said to commonly relapse after just PAIR therapy alone. So this is just an illustration of what these WHO classifications would look like on ultrasound. So in terms of indications for surgery, so surgery is the treatment of choice for the management of complicated cysts. So these are cysts that have ruptured, or cysts with biliary fistulae, cysts that compress on vital structures, or cysts with secondary infections or hemorrhage. Surgery is also warranted for the management of cysts with many daughter vesicles that are not suitable for percutaneous treatment, and this would be WHO CE2 or CE3B if you go back to the table. Other indications for surgery would include large cysts, so diameter more than 10 centimeters, any cyst that's very superficial because of the risk of rupture even from minor trauma, and if there's any extrahepatic disease, so if there's lung, bone, brain, kidney involvement. Surgery is also appropriate in the settings where percutaneous treatment is obviously not available. In terms of complications for surgery, so surgery may cure the patient, but morbidity, mortality, and relapse rates can vary. Complications for surgery would include things like secondary infection of the cyst cavity, intra-abdominal abscesses, biliary fistulae, sclerosing cholangitis, and they may actually spill the contents of the cyst into cavities and cause secondary echinococcus and anaphylaxis. Post-operative complications, however, occur in less than 1% of cases. So this is United States data, not ours. And recurrent echinococcus occurs in about 2 to 25% of cases. Then adjunctive therapy should be administered to minimize the risks of secondary echinococcus from seeding of the protoscoloces in the abdominal cavity in the event of fluid spillage. And this is a case where you would probably want to extend the duration of therapy if there's any spillage. So albendazole has been used, and some studies have recommended praziquantel, but the efficacy is really not very well documented. Okay, then lastly, almost done, in terms of PAIR. So PAIR is a less invasive technique than surgery and can be both diagnostic and therapeutic. And the cure rate of PAIR is approximately 95% or more than 95% in some instances. And PAIR may be used for the primary treatment of WHO CE1 and CE3A cysts. So these are cysts that do not have daughter cysts. For the treatment following relapse of CE1 or CE3A cysts that was previously maybe managed by medical therapy alone, or for treatment following relapse after the surgery. And the PAIR is usually performed with guidance from ultrasound or CT. And what happens is the cyst is punctured. You aspirate fluid and you evaluate the fluid for protoscolosis. And then you inject a protoscolocidal agent. And this could be things like absolute alcohol. In some instances, hypertonic saline is recommended. Formalin can be used. Chlorhexidine can be used. But you inject the scolocidal agent and then you re-aspirate after about 10 to 15 minutes. And the presence of protoscolosis in the re-aspirated fluid means that you need to repeat the injection again. Adjunctive drug therapy with albendazole or imibendazole should be administered at least 4 hours before you're attempting PAIR. And albendazole should be continued for about a month after the procedure, and mebendazole continued for longer, so about 3 months after the procedure. There are few contraindications to PAIR. So if the cyst is maybe not drainable, or if it's a superficial cyst at risk for rupture into the abdominal cavity, or if the cyst is already ruptured into the peritoneum, or if there's any biliary communication that's suspicious, or if there's an inactive or calcified cyst as well, you should not be going ahead with PAIR. Okay, and then these are some of my references, and that brings us to the end.
Cool, thank you. Thanks so much, Tyral. I'm just going to post the link for the CPD point again in the chat. So yeah, so you covered it really nicely. Some of the questions in the chat, some have been messaged to me. Professor Freen was mentioning that just to FYI for the audience, the tinidazole and the luminal agents for amoebic liver abscesses aren't available, unfortunately, in South Africa, like paromomycin and others. So we really are stuck with metronidazole alone. That's the bulk of the job. I mean, you're going to get the patients better with the metronidazole, but it's really just the onward transmission from the luminal side that we're not covering. Mm-hmm. Mary Ross was asking, is there any evidence of occupation playing a role in the incidence and male preponderance of liver abscesses? Is that maybe why it's more males?
So I think that has been suggested among other things, but there hasn't really been any clear-cut data as to why. Like I said, the most promising thing was some association with testosterone that I found. But again, nothing that was, solid.
Yeah, and as Professor Cottman's added that Ascaris is implicated in children, obviously, is one thing, but it's a separate question, but related. As a rare but exciting cause of liver abscesses. Then a couple of the common questions, I guess, in terms of the treatment for the liver abscesses itself, there's the pyogenic abscesses. The Americans always recommend sort of piperacillin tazobactam. I mean, in our setting, augmentin will be fine for that for pyogenic liver abscesses. The reason they don't have intravenous augmentin and the ampicillin sulbactam, which they have, which is similar, actually doesn't cover the enteric flora like E. coli as well. So they tend to, they overcall it, but then we often see our registrars following those guidelines and sort of putting on to piptazo. No reason in South Africa to do that, unless you're worried about resistance for whatever reason. And then a question we often get asked is when would you empirically cover amoebic liver for liver abscesses that there may be amoebic? Because obviously most of them are pyogenic, very few of them are amoebic. But what would you do in terms of therapy? Because something like augmentin obviously wouldn't be stretching to the amoebic side of things.
Yeah, so I guess you'd have to think about the patient, right? So they have to be in the right clinical context. Maybe if they have any exposures that that may be consistent, so a history would be important. But then you'd have to do serology as well, right? So you'd have to wait for your serology to come out. But empirically speaking, yes, so you should be giving, so if we're going to use augmentin in our setting, then you should be adding something like metronidazole for, yeah. And either does that answer the question, Jeremy?
Yeah. So I think, I mean, I'm sort of allergic to augmentin plus metronidazole for the double anaerobic coverage, but you're right, using it for different setting. I mean, what's often done is ceftriaxone, for example, plus metronidazole, which covers both, and is a pretty good upfront cover. It's a tough one. I don't think we have a good sense of when to cover empirically for it. I agree with you. You can look at the patient to some degree, and it also depends on how long it's going to take to get your serology back. Right. If it's a 10-day delay, then it's quite different to if it's 2 days. A tough one. You mentioned the sort of intravenous to oral switch. I must say I tend to disregard most of that these days if you've got good bioavailable agents. Is there good evidence for intravenous versus oral here, or is it just really the sort of historical legacy of preferring intravenous for severe infections?
So I wouldn't say good evidence, Jeremy. This is just the most concise recommendation I found from up to date. But no, there's no good really evidence for intravenous and oral switch down. Yeah.
I'm always sort of cognizant of remember the famous thing that the bug doesn't know where it came in by the vein or the stomach. So it's really just about the tissue levels and to some degree the blood levels that get to the tissue. So I think if it's a high bioavailable agent, I wouldn't mind much. I mean, we're not talking about a patient who looks like they're in septic shock or something where clearly you can't be sure of the oral bioavailability of any drug. Leo's asking a very good question, which I don't know. Maybe John does. I'm going to make John co-host, but you may know as well, Tyral, about the metronidazole dosing is higher for pyogenic. Is it? So it's usually written as 750, which was closer to 800.
So
do we have any idea why it's that high? Is it just the different bug, different dose, or is there something more to it?
I'm not sure. Perhaps Prof can answer that.
No, I don't know. Presumably it's based on some sort of published experience, but I don't know.
Yeah. I think it may just be, as you said, the different. There's no reason to assume. I guess the normal dose for bacteria will work for the protozoan. But
just
go ahead.
Just one comment on using metronidazole. So this issue of lack of access to luminal agents came up a while ago for the SAMF, and I didn't find a publication somewhere which suggested that if you use metronidazole for long enough, for more than a week or so, then you do effectively get rid of the cyst, and an luminal agent isn't required, but that may expose the patient to metronidazole side effects for longer. So I think the SAMF may still carry that recommendation. I'm not sure.
Yeah, that's interesting, because I guess, I mean, obviously not necessarily for intestinal, but for liver amoebic abscesses, you would be giving it for that long. Usually, you wouldn't wouldn't get away with less than 7 days. So, so that's
Yes,
encouraging.
yeah,
If
exactly.
so, yeah. And then we'll start with you, Tyral, and we can pass on if you know for other comments as well. But it's interesting about this albendazole before the surgery for hydatid liver abscesses. Most of the American and many of the European guidelines do suggest quite a long period of time. You said at least 4 days, but many of them sort of prefer a week or two. The teaching from South America from the Gorgas course is the opposite. They say that all it's really doing here, because if you know you're going to, so we're talking about a patient who's going to need excision of the cyst. So we're not talking about a pair procedure necessarily, but the same would apply. But with excision of the cyst, all you're doing when you're giving a long course is you soften the wall, and it makes it harder for the surgeon. And if you
And
think
they've
about it,
complained about that.
yeah, and
Yeah.
they really, you know, your job here is really just to have therapeutic drug levels at the time of surgery in the case of spillage. I mean, that's the role. You're not assuming that medical therapy is going to work. You're really just saying you want it on board so that it's therapeutic if they spill, because they usually do. It's very difficult often. And so in that sense, I mean, the sort of Gorgas course teaches sort of 48 hours or so. I mean, that seems about right, I must be honest. I don't mind if you want to give it 4 days, but I just think it makes no sense to give it for sort of a week or two. It just seems rational, unless I'm missing something.
In fact, at Joburg Gen, we quite recently, it was actually one of your cases, Jeremy, that came across to us, to cardiothoracics, and they would also refuse to give it earlier. So they'll probably do 24 hours even before surgery, and they wouldn't want to do it earlier because it increases the risk of spillage so much.
Yeah, I mean, the half-life, I had to look it up, but the half-life is about 8 to 9 hours. So, you know, 4 half-lives for therapeutic drugs. So you're looking at kind of a day and a half, really, at most. And there's a lot of back of the envelope about that. But yeah, I mean, I agree, sort of a day to 2 days at most, not more, I think. I mean, I don't know, John, is there any other rationale for giving it for longer than that we're missing?
No, not really. As Tyral says, the surgeons don't like using it for longer.
Yeah, for once I agree with the surgeons. So we'll on that very happy note, we can probably close, because it's surgery, and then Lyle said there's specific indication to avoid pre-surgery albendazole for pulmonary cysts. Yeah, agreed. It's not always in the international guidelines that way though, which is fascinating, but it is in, I think, locally and some other guidelines. It's very interesting. Okay. Thank you, Tyral. That's really good job. 4 o'clock on the dot. So well done, everyone. And I've posted the link for the CPD points. I'll post it one more time here. But in the meantime, we can get going with the second half. I'm going to stop recording.